Hello to everyone. My name is Helen Herrera and today I'm going to talk about epidemiology of acute kidney injury in critically ill children and young adults. But first, I'm a med student at Universidad Católica de Santiago de Guayaquil, and here are my Facebook, Twitter, YouTube, and Instagram accounts so you can follow me and watch the other videos. Definition: acute kidney injury, aka, is a sudden episode of kidney failure or kidney damage that happens within a few hours or a few days. AKI causes a build-up of waste products in your blood and makes it hard for your kidney to keep the right balance of fluid in your body. Stages. This definition identifies an stages AKI based on change in serum creatinine from baseline or urine output. Baseline creatinine is defined as the lowest serum creatinine value in the previous 3 months. Estimating the baseline glomerular filtration rate using the original Schwartz equation, where no previous serum creatinine measures are available, it is recommended to use percent baseline of 120 millimeters per minute per 1.73 square meters.
Acute kidney injury, AKI, also known as acute renal failure, is a sudden, rapid loss of kidney function, typically within days or weeks. The function of the kidneys is to filter blood plasma, removing metabolic wastes in urine while also adjusting urine composition to maintain balance of various blood parameters. In AKI, metabolic wastes accumulate, and fluid, electrolyte, and acid-base disorders may develop quickly. Of the many possible complications, most serious are potassium overload, hyperkalemia, and excess of fluid volume, or hypervolemia. Usually both kidneys must fail for AKI to be diagnosed. While AKI can be caused by a rapidly progressing intrinsic kidney disease, it is most commonly a consequence of an underlying condition outside the kidney. Causes are classified as pre-renal, renal, and post-renal, with pre-renal being most common. Urine formation occurs in the functional units of kidneys, called the nephrons. Blood enters the nephrons via the afferent arteriole, passes through a ball of capillaries called the glomerulus, where filtration takes place, then leaves via the efferent arteriole. Blood pressure inside the glomerulus must be high enough to enable filtration. This is achieved by having the afferent arteriole significantly larger than the efferent arteriole, creating a blood flow with a large inlet and small outlet. Pre-renal AKI is usually due to an inadequate blood flow to the kidneys. Major causes include extracellular fluid volume depletion and decreased blood pressure, both of which reduce the glomerular filtration rate. Normally, autoregulatory mechanisms within the kidney, which dilate the afferent arteriole in response to volume loss, can compensate for a certain degree of low blood flow. AKI develops when hypoperfusion is severe, or when these mechanisms are compromised in patients with pre-existing chronic kidney disease. Medications that cause dilation of the efferent arteriole or constriction of the afferent arteriole reduce the pressure inside the glomerulus and may contribute to development of AKI. In patients with pre-renal AKI but otherwise healthy kidneys, renal function typically returns to normal after the underlying condition is resolved, or the offending drug is discontinued. Renal causes refer to intrinsic problems within the kidney, such as inflammation or necrosis of any of its components, the glomeruli, renal tubules, and interstitium. Post-renal causes include various types of obstruction in the storage or voiding parts of the urinary system. These range from microscopic obstruction within renal tubules to blockage of ureters by kidney stones, to urethral obstruction due to enlarged prostate in men. Some AKI may involve problems at more than one level. For example, renal hypoperfusion, a pre-renal cause, may sometimes be severe enough to induce ischemia of renal tubule cells, leading to intrinsic kidney disease. As the cells die, cellular debris may clog the tubules, becoming a post-renal cause. Initially, symptoms of AKI are commonly masked by those of the underlying condition. In a later stage, symptoms are due to accumulation of nitrogenous wastes and disturbances of fluid and electrolyte balance. Urine output may or may not be reduced. Diagnosis is based on renal function tests, such as serum creatinine and urea, serum electrolytes, urinary sediment, urine output, and urinalysis. Cause must be determined. Pre-renal causes are usually apparent. Ultrasound is commonly performed to detect post-renal blockage. Treatments aim to address the underlying cause, although some patients may also require fluid and electrolyte management or dialysis.
Application in medicine. The incidence of pediatric acute kidney injury, AKI, is increasing globally, as are the associated morbidities and mortality. A recent standardization of the definition of AKI has allowed for a more accurate assessment of the epidemiology of pediatric AKI. Recent advances in leveraging electronic medical health record systems have allowed for real-time risk stratification and prevention of pediatric AKI in the hospital setting. Newly developed and validated clinical scores have improved our ability to predict AKI and provide a rational context for biomarker utilization in hospitalized children. Novel non-invasive diagnostic and predictive biomarkers have been launched globally to improve our ability to diagnose and predict AKI and its adverse outcomes as well as recovery.
Acute kidney injury is an acute condition. It happens rapidly. It causes a loss of renal function. It affects millions of Americans, more than 1 million Americans a year. It causes a doubling of the hospital mortality and hospital length of stay, and causes millions, in fact, billions of dollars in cost to care for. And it causes long-term disability in terms of chronic kidney disease, need for dialysis, and conditions like increased risk for cardiovascular disease. It's very difficult to diagnose, which is part of the problem for treatment. Early on, there's no symptoms. It's a silent killer. Later, it's diagnosed by changes in function, which are manifest by changes in serum creatinine or urine output. But by then, there's often already a loss of kidney tissue. In terms of treatment, right now, treatment is largely supportive, although the hope is that new emerging therapies will be useful in the future. Supportive therapy, though, is important because there are the two most common causes of acute kidney injury are sepsis and nephrotoxic medications, and we could do something about both of those. We can identify sepsis and treat it with antibiotics and source control, and we can identify nephrotoxic medications and discontinue those or choose better alternatives. The Center for Critical Care Nephrology here in Pittsburgh is devoted toward bringing together scientists and clinicians from a wide range of disciplines to address this problem of acute kidney injury and related conditions, but acute kidney injury in particular is such a difficult problem that really requires a multifaceted approach. Some of our major accomplishments have been to actually initiate in the hospital system an alert for acute kidney injury. It's in the medical record system. It goes back and finds baseline serum creatinine, which is a measure of renal function, and looks at the change between that measure and a current measure, and tells people that that change has occurred, and gives them sort of a leg up in terms of noticing that this is a problem. Our scientists have led the field in terms of developing studies which have demonstrated the validity of a new biomarker panel for detection of acute kidney injury, or risk assessment of acute kidney injury, which recently FDA approved. So I think the most important thing physicians need to understand, and when I say physicians, I mean not just nephrologists and intensivists, but physicians in different disciplines. Much of acute kidney injury is first seen by family practitioners, emergency room doctors, orthopedic surgeons, and so by the time intensive care doctors and nephrologists see them, it's often too late. So I think it's very important for physicians to understand that this is a common problem, that it causes severe long-term disability as well as short-term illness and death.
Pros and cons. Pros. Despite the ever-expanding body of knowledge surrounding AKI in the pediatric population, management at this time is still chiefly limited to reducing risk factors and providing supportive care. There is still a lack of curative treatment. At this time, validated strategies available in the current literature primarily focus on injury prevention and mitigation. Cons. Acute kidney injury (AKI) is described as a spectrum of abruptly compromised renal functions that result in impaired balance of fluid, electrolytes, and waste products. It is recognized as an increasingly common cause of morbidity and mortality in children. Epidemiologic studies involving adults have shown that acute kidney injury is associated with increased mortality, prolonged mechanical ventilation, and prolonged length of stay in intensive care units.
Here are 5 things healthcare professionals should know about drug-induced kidney injuries. First, there are three main ways that drugs damage kidneys. Some drugs decrease how much blood flows to the kidneys. Examples include NSAIDs, ACE inhibitors, and ARBs. Some drugs directly injure kidneys. Examples include penicillins, cephalosporins, contrast dyes, and aminoglycosides. Some drugs also obstruct the flow of urine from the kidneys. A common cause is calcium stones from excessive or high-dose calcium supplementation. Second, patients at higher risk may include those aged 60 or older, experiencing dehydration, with diabetes, high blood pressure, pre-existing kidney disease, heart failure, or liver failure, or having recently had surgery or a procedure that used contrast dye. Third, symptoms can occur days or months after starting a new drug. Most mild to moderate kidney injuries do not have any symptoms. People with a severe kidney injury may complain of feeling tired or confused, a sudden increase in blood pressure, a sudden change in urine output, or swollen ankles and weight gain from fluid. Fourth, the most useful lab markers are an increase in serum creatinine by at least 27 micromoles per liter in 24 hours or by 50% in 7 days, a drop in eGFR by 25%, and/or a decreased urine output. Finally, patients who experience a drug-induced kidney injury may need to have their medication doses decreased or stopped altogether.
Issue in Ecuador. In Ecuador, the prevalence of AKI is 10% of the population, and it has high undocumented mortality rate. A prospective study carried in Quito analyzed 2279 patients admitted at ICU, and the 9.2% met the criteria of AKI. The main cause was sepsis. Finally, the conclusion. This large prospective multinational study of the epidemiology of acute kidney injury in children and young adults in ICUs showed that acute kidney injury occurred in 1/4 of patients during the first 7 days after ICU admission. Severe acute kidney injury conferred an incremental risk of death by day 28 and was associated with increased use of renal replacement therapy and mechanical ventilation and longer stays in the ICU. And there is a video about an example case.
What's up everyone, it's Jessica and welcome to Critic. In my videos on acute kidney injury, you've learned the definition, how to interpret serum creatinine, and the workup to the respective causes of acute kidney injury, pre-renal, renal, and post-renal. In this video, I'll walk you through how to go about the entire workup when encountering such a patient. Let's go. You're consulted by the orthopedic surgeon to take a look at her patient she's admitted yesterday. 64-year-old Mr. Cohen is supposed to get knee replacement surgery, and the surgeon performed labs today, which showed a creatinine of 120 micromoles per liter. Previous value was 80 only 1 week ago. So, acute kidney injury. Let's go through this. In your mind, you already go through the causes. Pre-renal, you want to get a sense of his volume status. So, fluid loss like vomiting and diarrhea or less fluid intake. And drugs like ACE inhibitors, NSAIDs, and diuretics. Let's calculate the fractional excretion of sodium. Renal, ATN, low flow states, drugs, deposits. And TIN, UTI and drugs. And don't forget glomerulonephritis, but we might see that in the urinalysis. Right, get a urinalysis. Post-renal, could he have an obstruction? Consider an ultrasound. History and exam tells you that Mr. Cohen has had coronary bypass surgery 7 years ago. He doesn't have heart failure. He's an active man that takes his medication faithfully. His list of meds is short: metoprolol, lisinopril, and an aspirin. He also started taking Advil from the store for the last 2 weeks as his knee keeps hurting. 2 days prior to admission, he'd eaten a bad sandwich which led to severe diarrhea. The next day, 1 day before admission, he He felt a whole lot better, so he didn't think it was important to tell the surgeon. He stopped eating and drinking at midnight due to surgery the next day, and he didn't get an IV drip. He doesn't have a fever, no pain at urination, no pain in his abdomen, sides or back, and his urine looked normal. He didn't notice that he peed either more or less often. This sounds pretty pre-renal already. Diarrhea combined with an NSAID and an ACE inhibitor. The labs you need are the following. Serum creatinine and sodium for the fractional excretion of sodium. You don't really need urea since he's not on diuretics. You'll need all the other electrolytes, especially potassium and phosphate, to check for possible complications. If renal clearance decreases, you could get serious hyperkalemia. You also need a urine sample for the urinalysis. You'll want to know if there's red and white blood cells, nitrite, protein, etc. And you need a sample on urine creatinine and sodium for the fractional excretion. Labs are in. Okay, so the fractional excretion of sodium is less than 1%, which indicates pre-renal kidney injury. This also fits the history and exam. You go through the other causes in your mind. ATN isn't likely as the duration of the dehydration wasn't that long. He doesn't have a UTI, and the urinalysis doesn't fit either a glomerulonephritis or a TIN. Post-renal is always a possibility, and it isn't excluded yet. But you have a sufficient explanation for now, so there's no need for an ultrasound at this moment. You advise an IV drip, cessation of the lisinopril, monitoring urine production with a catheter, and checking serum creatinine and electrolytes the next day. If renal function doesn't improve within 48 hours, you repeat your labs and advise an ultrasound. And that's how I go about acute kidney injury. I hope these videos were helpful to you in your daily practice. Please let me know in the comments section. Share.
Thank you for your attention.